This one. Sound ಅದನ್ನ ನೋಡ್ತಾ ಇರಿ. Clarity. Start ಮಾಡಲ್ಲ. Good morning, students. We'll be continuing with pathology class, RBC disorders. Okay, that is anemia. Today we are going to discuss about hemolytic anemia. Hemolytic anemia is a very big chapter for you. So many questions, 10 marks, 5 marks, 3 marks. You get a lot of questions from hemolytic anemia. Okay. We classified anemia as one was due to blood loss, one is due to impaired production. Last time we read about iron deficiency, megaloblastic and everything. And this is due to increased destruction of RBCs, also known as hemolytic anemia. Hemolysis is rupture of RBCs. Anemia is any condition which leads to decrease hemoglobin for that sex and age. Okay, either due to directly decrease in the hemoglobin or decrease in the RBC count. What happens in hemolytic anemia? Hemolysis. We know RBC half-life is around 120 days. After 120 days, it becomes less fragile. It becomes fragile. It's taken by the spleen, splenocytes and splenic macrophages, and they phagocyte it. Okay, so what happens in hemolysis? It's premature destruction of RBCs. It's less than 120 days. The RBC doesn't become complete mature. In premature condition only, depending upon the disease process, you take 15 days, 20, 40 days, 50 days, it gets destructed. It gets ruptured. So once RBC is ruptured, okay, above the RBC you have hemoglobin, so that is also gone. So it leads to decrease in hemoglobin, and also it decreases the RBC count also. Okay, you get abnormal forms of RBCs in the blood smear. I will show you the pictures later. So hemolytic anemia itself is a very big chapter. It will take 2-3 classes for you. Okay, today will be a little bit of introduction and some classifications. So what is hemolytic anemia? It's premature destruction of RBCs in less than 120 days. Okay, so what happens when RBCs are destroyed? You know the RBC metabolism. Okay, once RBC is destroyed, the globin is taken back. The heme protein gets converted to protoporphyrins. They are released, comes to biliverdin, then comes to bilirubin. That is unconjugated. That is unconjugated bilirubin. Okay, or indirect bilirubin. Then it is taken up by the liver, where it undergoes conjugation with albumin, so that it becomes water soluble. It gets excreted in liver, in stool and urine. Most of the part is taken back by the intrahepatic circulation, back by the liver. Okay. So here what happens when there is a premature lot of rupture of RBC, there is accumulation of products of hemoglobin metabolism. So when RBC a lot of rupture, we get unconjugated bilirubin or indirect bilirubin. Okay. So that get accumulated in the blood. Blood has not yet reached the liver, so that undergoes conjugation. It is in very early phase. So whenever we get in hemolytic anemias, we get unconjugated bilirubinemia. Okay, it's also known as indirect bilirubin. So the indirect bilirubin levels is very high. So what bone marrow does to the compensate? Okay, RBC are getting destroyed. What bone marrow will do? It will increase the production of erythropoiesis. Okay, all the stages, pro-erythroblast, early normal blast, intermediate, late reticulocytes. It increases the production so that more and more cells goes to the periphery and tries to compensate the hemoglobin. Okay. So this is one picture of the splenic sinusoids. You can see in the center red cells are there in the splenic sinusoid. When these red cells pass through the endothelium, okay, and they become fragile, old, they are taken by the macrophages and they destroy it. So this is classification of hemolytic anemia, very important for you. Okay, anemia classification itself is very important. In that you have hemolytic anemia subclassification. We divide hemolytic anemia subclassification as extracorpuscular and intracorpuscular. Okay, that is extrinsic causes, that is extracorpuscular abnormalities. Okay, abnormalities above the outside the RBC cell. These are all are acquired conditions. So we classify as extrinsic extracorpuscular abnormalities. The another one is intrinsic, heredity, intravascular abnormalities. Next PPT we will see. So what are the subclassifications in this one? We have antibody mediated. Okay, antibody destroys the RBCs. You have isoimmune. Okay, isoimmune, same antibodies produced in your body, that's seen in transfusion reaction, and another is erythroblastosis fetalis. Transfusion reaction, when you have other blood group are mixed in the same blood, you get antibodies are produced against the wrong blood. That leads to transfusion reaction. Erythroblastosis fetalis, I will discuss you later. Autoantibodies, our own body produces antibodies against the RBCs. We have most common idiopathic drug associated. One condition is SLE, systemic lupus erythematosus, lot of malignancies. Okay. Then one more is autoimmune hemolytic anemia. Okay, you know hemolytic anemia. What is autoimmune? Our own immunity produces antibodies against our own cells. So in that we divide into further warm antibody autoimmune hemolytic anemia and cold antibody autoimmune hemolytic anemia. Both are 3 marks question. We'll discuss later. Okay. Mechanical trauma, outside mechanical trauma. Okay, you have microangiopathic hemolytic anemias. Okay, microangiopathic, within the blood vessel there is lot of, as the blood flows in the vessels, there are some conditions where the blood has to flow through it, and there happens the hemolysis. You have condition like TTP, thrombocytopenic purpura, DIC, disseminated intravascular coagulation. Cardiac traumatic hemolytic anemia, because of abnormal cardiac walls. Okay, hemolytic anemia can be seen. So many infections, you have malaria, bacterial infections, chemical injury. One common is lead poisoning. Okay, we have one condition known as hypersplenism, where the spleen acts more aggressively. Okay, it leads to sequestration in the mononuclear phagocyte systems and it starts eating the RBCs. Okay, there is one acquired red cell membrane abnormality that is known as PNH, paroxysmal nocturnal hemoglobinuria. We'll discuss one PPT at the last. So the another classification is intrinsic or intracorpuscular abnormalities. Intrinsic means the defect is within the RBC cell only. Something is cell wall, cytoplasm, nucleus, something defect is there in the cell that is leading to the RBC hemolysis. So abnormalities of the red cell membrane. You have condition like hereditary spherocytosis, hereditary eleptocytosis, hereditary stomatocytosis. Disorders of the red cell interior defects. You have red cell enzyme defects like enzymopathies, deficiency in the enzyme. You have defects in the HMP pathway shunt, G6PD deficiency. You have defects in the embedded MF4 glycolytic pathway. Most commonly is pyruvate kinase deficiency. Or there is disorder of hemoglobins also. We call it as hemoglobinopathies. Okay, structural abnormal hemoglobins. Like you have abnormal structural hemoglobin, like you have most commonly sickle cell anemia, and other few hemoglobinopathies we'll discuss next class. Or there is reduced globin chain synthesis. You know hemoglobin, one part is globin, and if the globin chain is only reduced, okay, that is known as, that condition is known as thalassemias. So today we are going to discuss only about the extrinsic extracorpuscular abnormalities. Okay. What do you mean by extravascular hemolysis? Okay, destruction of senescent fragile RBCs in the mononuclear phagocytic cells that happens in spleen. Okay, what happens? These injured, deformed RBCs. Okay, like conditions you have hereditary spherocytosis or sickle cell anemia, where the RBC cell wall is abnormal. Okay, the macrophages easily take up that cell for phagocytosis. Clinically, you see anemia, decreased hemoglobin, jaundice. I told you whenever RBC ruptures, you get unconjugated bilirubin levels are very high. Okay. So it's also known indirect bilirubin, decreased haptoglobulin. Haptoglobulin is a protein secreted by liver. It binds to the HB products. So the levels of the haptoglobulin decreases. Also you get splenomegaly because spleen is sequestering all the RBCs. Okay. Whenever you have extravascular hemolysis outside the vessel, hemoglobinuria and hemoglobinuria you don't see. You see hemoglobinuria, that is the blood haemoglobinuria, hemoglobin in the urine. We see only in intravascular hemolysis. So what is intravascular hemolysis? Okay. Within the vessel wall, the blood is flowing. Okay, something like fibrin, thrombi, or cardiac wall coming like on the way, and there is constant destruction of the RBCs. Another one is antibody mediated. Okay, some kind of toxic factor infections like malaria and any other infections also can cause hemolysis, severe infections. So what are the lab findings you see in intravascular hemolysis? There is a hemolysis within the blood. Hemoglobinuria. Hemoglobin is released. It is seen in the blood. That is known as hemoglobinuria. Serum hepatoglobin levels are reduced because it binds to the hemoglobin product. So its levels are reduced. Hemoglobinuria. Urea is urine. Last 3 words. Urea is urine. Hemoglobinuria is presence of hemoglobin in urine. Jaundice due to increase in the unconjugated bilirubin or indirect bilirubin. Okay. Then you have in intravascular hemolysis, splenomegaly is not seen. So what are the investigations, routine investigations we see in hemolytic anemia? Hemolytic anemia we have a lot of hundred of causes for that, but today just we are going to see about the introduction. Okay. What are the routine investigations? One is peripheral smear. Collect the blood from the patient, make a smear on the slide, stain it, and you can see in the 100x oil immersion microscope. It will be taught you in practicals. Okay. peripheral smear we see fragmented RBCs, ruptured RBCs. Fragmented RBCs means ruptured RBCs. Nucleated RBCs. Nucleated RBCs are precursors of the RBCs. Whatever proerythroblast, normal blast, whatever you see, we call them as nucleated RBCs. Okay, when seen in the blood. Polychromatophil cells. Polychromatophil cells are nothing but RBCs on the surface. It shows little bit of bluish tinge. They are nothing but reticulocytes again. Okay, they are produced more and more by the bone marrow as a compensatory mechanism. We see abnormal cells of the RBCs like spirocytes. Okay, RBC cell with no central pallor. Sickle cells, when the RBC cells take the size of a sickle. Target cells, we see when there is hemoglobin condensation in the center of the cell, that is appears like a target cell. Cystocyte is a ruptured cell. Okay, whenever RBC undergoes rupture, the remaining ruptured cell looks like cystocyte. Acanthocytes, a RBC cell which has a lot of projection on the cell surface. I'll show you the pictures later. Reticulocytosis, we know reticulocytes is a premature RBC, just one stage before the mature RBC producers. So bone marrow in hemolytic anemia, RBC are getting ruptured. So bone marrow will try to compensate, produce more and more erythroid series from pro to early normal blast, early to late. So cells are continuously produced, and we see reticulocyte stage in the peripheral blood. What we see in bone marrow? Bone marrow is producing erythroid series a lot. So the cellularity is increased. The myeloid erythroid ratio is 1:1 to 1:6. Okay, so erythroid series we see erythroid hyperplasia. We see extramedullary hematopoiesis. Extramedullary means outside the medulla, bone marrow. Some places we are seeing blood production also. We call it as extramedullary hematopoiesis. Okay, as we know, the bilirubin increases, unconjugated bilirubin, indirect bilirubin levels increase in the blood. It leads to cholelithiasis, gallbladder stones. We'll discuss later. Hemosiderosis. Okay, as the RBC is getting broken down, more and more hemoglobin release. It is again taken up by the bone marrow as iron stores. So there is a lot of overload of the iron stores. That is known as hemosiderosis. So other lab findings, what we see in the blood, we see increased serum unconjugated bilirubin. Unconjugated bilirubin or indirect bilirubin. It has not undergone conjugation. Okay, it is water insoluble, it is lipid soluble. Okay. So increase urine urobilinogen. Okay. Raise fecal stercobilinogen. The bilirubin undergoes conjugation in the liver and further it is excreted. Okay, decrease serum hepatoglobulin, it's in all hemolytic anemias. Always remember, whenever we see bilirubin, whenever we say bilirubin in hematology, it is unconjugated bilirubin only. Okay. This is one picture for you. Okay, just a peripheral picture where you are showing all the normal RBCs in the center. Okay, in some corners you are seeing sickle cell RBCs, slender, long shape RBCs. In the above you can see some crenulated RBCs. Okay. In the upper part you can see some RBCs, they are all ruptured RBCs, okay, or cystocytes. This is one condition of G6PD, we will discuss later. You can see the RBC in the center RBC, it's like a bite cell. Somebody has taken the bite of the RBC. These are all ruptured RBCs. So coming to polychromatophil, I told you polychromatophil is indirectly reticulocyte only, but in normal state, you can see the right lower part, there is a RBC on the over of the surface of the RBC, little bit of bluish tinge is there. Okay, so that is a polychromatophil cell. Okay, you can see on the right lower side, it's nothing but a RBC only with little bit of, usually RBC will be of grey color when we stain greyish. Here we have light bluish tinge appearance. Okay. We know in hemolytic anemia, reticulocytes are a lot of release in the blood, so we get increased reticulocyte count. Normally it is around 0.5 to 1.5% in adults, but here this is a special retic stain. You can see the reticulocytes have the RNA in the cytoplasm. Okay, it's a nucleated structure, so we stain that nucleated structure with supraorbital dyes. Okay, so that is why we see in the, you can see the 1, 2, 3, 4 cells which have inside purple stains. These are the retic stains. They are the RNA, reticulocyte RNA, which have taken the stains. Rest other cells are normal RBCs. It doesn't have genetic material. So these are the reticulocytes. So just this is an old picture for you. Will show you all abnormal RBC forms. First one is the spirocyte, where there is a normal RBC with no central pallor. Second is the cystocyte or bite cell or ruptured cell. Third is the irregular contracted cell. Okay. Fourth one is the target cell. You have central hemoglobin condensation appears like target. Fifth is the sickle cell. The RBC has become like a sickle. Okay. Sixth is the crenulated RBC cell. The RBC surface shows a lot of projections. Small progenitor become crenulated. Seventh is the acanthocyte. Acanthocyte is a small RBC with a lot of projection on the surface. The same is with Burr cell, big RBC with multiple projections. You have stomatocyte. It is a condition where RBC, we have the central lack of, you have central 1/3 pallor. Okay, here the pallor, normally the pallor will be round in RBCs. Here the pallor become horizontal slit. So we call it as stomatocyte. Another one is ovalocyte, where the RBC become ovalocyte. Okay, oval. Depending upon the severity, duration and the type of hemolytic anemia, we have a lot of diseases under hemolytic anemia. We get see that kind of anemia, we get jaundice, we get splenomegaly, we get gallstones, cholelithiasis, lot of skeletal deformities happens because of extramedullary hematopoiesis. Even we see leg ulcers. When such conditions comes, in next PPT classes we will discuss all that conditions there. So now we will discuss each condition in detail. Try to listen properly. Okay, then you can go and read the notes. Try to understand it. So first one we are discussing is the antibody mediated hemolytic anemia. In that the first category is alloimmune or isoimmune hemolytic anemias. Okay, where antibodies are produced in our own body. Okay. So for you, one is blood transfusion, where the blood, if wrong blood group is given to the patient, against ABO antigens, antibody are produced. The second one is hemolytic transfusion. The second one is hemolytic disease of newborn. Okay, or also known as the erythroblastosis fetalis or hydrop fetalis. This is one special condition. Okay, try to understand what is this. Okay, this condition happens in pregnancy. What happens when the mother is Rh negative? In blood grouping, there are two antigens. One is ABO antigen and another is Rh antigen. You have ABO antigen, A antigen, B antigen. Okay, another is O antigen, and we have four groups: A group, B group, O group and AB group. A blood group has A antigen, B blood group has B antigen, AB blood group has A and B antigen, O blood group has no antigen. Okay, the same way like antigens, there is another antigen known as Rh antigen. If the Rh antigen is present over the RBC, we call it as Rh positive, like A positive, B positive, AB positive. And if the Rh antigen is not present over the RBC, means it is negative, we call it as A negative, B negative and AB negative, so on. Same way, in what happens in hemolytic disease of newborn, this is a pregnancy condition. It happens in the fetus. What happens when the mother is Rh negative? You take the mother, she's having a blood group of A negative, B negative. Negative groups are very rare. 80 to 90% we always see positive groups. Most commonly is O positive, A positive, B positive. Rare is AB positive. Suppose a mother is suffering from Rh negative group, like A negative, B negative. We take any negative group. Okay, mother is suffering from Rh negative. Okay, here ABO antigens are not of much important. Here we are going to only see Rh antigens, whether the group is positive or negative. Suppose the mother is Rh negative, like take it is A negative. Okay, and the father, he is a Rh positive, like you take it as A positive or B positive. The baby will have some group, but what about the Rh? Okay, so here the baby, since the mother is Rh negative, means no Rh antigen. The father is Rh positive, means he has the Rh positive antigen. Okay, the Rh positive antigen process. Okay, after fertilization, Rh positive antigens, the baby take up the Rh positive antigen. So the baby will be Rh positive. Okay, this condition happens only when the mother is Rh negative, father is Rh positive. If the mother is Rh negative, husband is Rh negative, the child will be Rh negative because the Rh antigen is not there. And if it is opposite, if the mother is Rh positive and the father is Rh negative, no problem, the baby will be Rh positive. Mother will is Rh positive, baby is Rh positive, no problem, no incompatibility. Okay, so this happens only in condition when the mother is Rh negative, father is Rh positive. Okay, so your first pregnancy, the baby is born, the baby is Rh positive, you take any group, A positive, B positive, whatever, and mother is A negative or B negative. See the body's immunity. Body immunity doesn't have Rh antigen. The mother's body doesn't have Rh antigen. It is negative. It doesn't know. It has never seen Rh antigen, and the baby growing is Rh positive. Means the body will think that some RH person has entered in my body without my permission, and it may, cause damage to me in future. So definitely the mother's body will try to kill the RH RBCs. Okay, try to kill the baby. The RBCs is present on the RBC surface only. So the mother RBCs will try to produce antibodies so that to kill the fetal RBCs. In the first pregnancy, usually IgM antibodies are formed, first 6 months, 8 months. Okay, and IgM antibodies cannot cross the placenta and infect and damage the fetal RBCs. In first pregnancy, since IgM antibodies are there, it goes uneventful. The pregnancy will be completely normal, no evidence of hemolysis. Okay, let the baby have normal delivery, cesarean, whatever it is, let the blood mixing happens. Since it is IgM antibody formation, it doesn't cross the placenta, it doesn't damage, it doesn't hurt the fetal RBCs. So the problem starts in second pregnancy. In second pregnancy, again the mother is RH negative, the father is RH positive, they are planning for second pregnancy. The mother is RH negative, again this time the baby is, again it will be RH positive only from the father. Last time it was IgM antibodies. Okay, initial antibody production will be IgM, after more than 6 to 8 months it becomes IgG. Okay, in second pregnancy the antibodies will be IgG antibodies, and IgG antibodies can cross the placenta. So this time in second pregnancy onwards, the mother's IgG antibodies against the RBC RH antigen is going to cross the placenta and is going to damage the RBCs. It's going to lead to hemolysis, and it is a very dangerous condition. It can take the life of the baby also. So the child is RH positive, the mother is RH negative, IgG antibodies cross the placenta in the second pregnancy and it destroys all the RBCs. Okay, the baby will have a lot of jaundice within the womb only, and that condition we call it as hydrops fetalis, lot of edema, everything. We call this condition as hydrops fetalis. Okay, and overall we call this condition as hemolytic disease of newborn or erythroblastosis fetalis. This may be a 3 marks question for you. This is one of the cause of hemolytic anemia. After that, we will come to immune hemolytic anemia, also known as autoimmune hemolytic anemia. Normally, in our body, our own body produces antibody against our own RBCs, which the body should not produce. Okay. We classify autoimmune hemolytic anemia. It's a extracorpuscular defect. Okay, antibodies are produced from the outside. Based on the nature of antibodies, we classify it as warm antibody immune hemolytic anemia, cold antibody immune hemolytic anemia, and another one special is cold hemolysis. That's the warm antibody type, cold antibody type, and cold hemolysis type. That condition, third condition, known as proximal cold haemoglobinuria. What happens is warm autoantibody immunity anemia. What the condition is warm? Here the antibodies, they react with the red cells at the room temperature, that is 37 degrees Celsius. Okay, and they are of IgG types. Okay. These human red cells, they are coated with IgG antibodies. This bind to the surface of reticuloendothelial cells, especially the splenic macrophages in the spleen. Okay, they take it and they causes phagocytosis and it destroys the RBCs. These red cells coated with IgG along with C3 complement on the surface further promote the red cell leukocyte interaction and it leads to severe hemolysis. The spleen is particularly efficient in trapping red cells with IgG antibodies. So the major site for autoimmune hemolytic anemia warm is spleen. Where red cell destruction happens. This warm AIHA can happen at any age. Okay, the disease may occur without any cause also, but in 25 to 30% cases we have been seen with underlying causes. Okay, the most common type is 50% is idiopathic, 50% are secondary to some diseases. This disease tends to have remissions and relapses. Remissions means when you give treatment to the patient becomes completely fine. That is remission. Okay, relapses, again the disease comes back. Okay, and many cases the antibodies are directed against RH blood group also. Okay, these patients have moderate symptoms. So warm antibody type, warm AIHA, they are IgG mediated type. The most common is primary idiopathic 45%, secondary to some other diseases like lymphoproliferative diseases like you have Hodgkin's lymphoma, non-Hodgkin's lymphoma, CLL. Okay, next WBC disorders will be discussed in detail. Connective tissue disorders like systemic lupus erythematosus, lot of infectious diseases. Drug induced because of methyl dopa, penicillin, quinine group, you get warm type of autoimmune hemolytic anemias. These antibodies react with 37 degree IgG type. What you see in lab, you see normocytic or macrocytic anemia. Normocytic means the RBCs are normal size, macrocytic means the RBC size are increased. Also in peripheral we see spirocytosis. Okay. What else you see in lab findings? The patient will have mild to moderate chronic anemia, reticulocytosis. All hemolytic anemias will have reticulocytosis, prominent spirocytosis in the peripheral blood because bloods are getting sequestrated by the spleen RBCs, spleen macrophages. We have something known as Coombs test. We have a special test known as Coombs test, always known as antiglobulin test. What is Coombs test? It's a test we do on the serum, we do on the blood to detect the antibodies. These Coombs tests are done on the patient's blood to detect whether antibodies are produced in your body or not. Okay, so we call it as positive direct Coombs test or indirect direct Coombs test. Okay, I will tell you the mechanism later. Just remember, Coombs test is used to detect autoantibodies in your body. Any condition, suppose you are suffering from any condition and I want to see antibodies are there in your serum or not. Simple, get a Coombs test done. Okay, you have unconjugated or indirect hyperbilirubinemia. Coexistence immune thrombocytopenia along with venous thrombosis can be seen in one syndrome known as Ivan syndrome. Okay, in very severe cases you can get haemoglobinuria and haemoglobinuria also can be seen. How you diagnose immune hemolytic anemia? By doing Coombs test. Okay, what cells? These cells have red cell agglutination with antiglobulins, indicates presence of the antibody over the red blood surface. I will show you the mechanism later. Okay. This is the Coombs test. It's a bit complicated. I will tell you in very simple way. Try to understand. Okay, also known as antiglobulin test. Okay, this test we do on the blood of the patient. Okay, where we are suspecting antibodies production. We have direct Coombs test and you have indirect Coombs test. Okay, or direct antiglobulin test or indirect antiglobulin test. Okay. In Coombs test, we use something known as Coombs reagent. Okay, we do it for testing. Okay, that is known as Coombs reagent. In Coombs reagent, we have antibodies against full of antigens and antibodies. Try to understand. We use something known as Coombs reagent to mix with the blood. Okay, what happens in Coombs reagent? It contains all the antibodies against all the antigens. It binds to the all antibodies over the RBC surface. It is something like simple. I will tell you Coombs reagent means suppose you have a lot of RBCs over lot of RBCs and over the RBC you have a lot of antigens and you want to bind and make it an agglutinate. Use Coombs reagent. It will bind everything. Okay. So direct antiglobulin testing. It's a very simple test. Okay. What we do? We take a patient's RBCs. You have immune hemolytic anemia. Antibodies are already formed. You can see the picture. Antibodies are already formed. They are attached on the surface. Okay, antibodies are attached to the antigen over the RBC surface. It is the antigen antibody complex. It's already attached. It's the patient RBCs. Put anti-C3 or anti-IgG. This is nothing but Coombs reagent. Okay, what it will do? Coombs reagent. It will bind all the RBCs antibodies together, and it appears like a clump agglutination reaction, and it becomes positive. It's a very simple test. We call it as direct Coombs test. Okay. What we do, take the patient's RBCs, okay, and put Coombs reagent. So all the patient's RBCs, suppose it have antibodies over it, attached to the antigen, it gets together clump, and you see as a positive reaction. It's known as positive Coombs reagent. The second come is indirect antiglobulin testing. Okay, it's an indirect method, bit long-term method, long route method. Try to understand. Here we don't take patient's RBCs. We take patient's serum. Okay, we have separated serum from the cells, RBCs. We have taken the serum. Serum contains antibodies. Okay, you know it is a condition of autoimmune hemolytic anemia. The patient serum contains the antibodies. That is in the patient serum. You take the RBC cells. From where you will take the RBC cells? You can take it from the blood bank. You have a lot of RBCs, A positive, B positive, O positive, AB positive. That particularly we go for O positive because you know O blood group doesn't contain any antigens. Okay, so we want a blood group which doesn't have A and B antigen. It should not interfere with our test. So we take RBCs. We take RBC particularly from the O blood group. Okay, mix it nicely. Okay, the antibodies, if antibodies are present in the patient's serum, it will get attached to the O positive RBCs over the cell surface. Okay, for the antigens, it will bind it. Right, like in the next picture. Then add Coombs reagent. What Coombs reagent will do? So whatever antibodies are bind, Coombs reagent will bind all the antibodies together. It is like a universal antibody, Coombs test. It will take all the friends together to a party. So it takes all the RBCs over the antibodies and makes a clump. You get agglutination reactions, and that is a positive reaction. Okay. So this is known as indirect antiglobulin testing and direct antiglobulin testing. After warm antibody immunohemolytic anemia, we will come to the next is cold antibody immunohemolytic anemia. See the first word, it's cold. Okay, here antibodies are reactive in body at the lowest temperature at 4 degrees Celsius. At 4 degrees Celsius, it causes hemolysis. And in this we see further two conditions, that is cold agglutinin disease and paroxysmal cold hemoglobinuria. Cold, the first name is cold, very cold condition. Agglutinin reaction. Okay, it's a disease. The second one is paroxysmal cold hemoglobinuria. Paroxysmal means sudden. Cold, low temperature. Hemoglobinuria, urea is urine, presence of hemoglobin in urine. So paroxysmal, suddenly at a cold temperature you are getting hemoglobinuria, hemoglobin in the urine. That is known as paroxysmal cold hemoglobinuria. So coming to the first condition, cold agglutinin disease. Okay, here the antibodies are IgM. Okay, and most active at the in vitro temperature at 4 degrees Celsius. In cold agglutinin disease, the antibodies are IgM type and which binds to the red blood cells at 4 degrees Celsius. These antibodies are usually directed against the antigen of the red cell surface. Agglutination of the red blood cells by IgM, cold agglutinin disease, most profound at very low temperature, and upon warming the temperature to 37 degrees Celsius, these agglutinations disappears again. The hemolytic effect is mediated through fixation of C3. Most cold agglutinin disease affect juvenile red blood cells, not old red blood cells. We see vascular obstruction, pallor, cyanosis. Okay, also body part of the exposed to the cold temperature, that is Raynaud's phenomena. Raynaud's phenomena, when the patient is exposed to the cold temperature, extreme cold temperature, you get cyanosis of the body part, exposed cold temperature, also pallor. Okay. So further with cold agglutinin disease, in which conditions we see this condition? Patient suffering with acute mycoplasma infection, infectious mononucleosis, or some self-limited viral illness also. Chronic conditions, most commonly it is idiopathic, the cause is not known, and also is associated with many lymphomas. So what are the mechanism of hemolysis in cold agglutinin disease? The complement activation with membrane attack complex results in lysis of the red blood cells. The C3b opposite red cells are removed by reticuloendothelial cells, macrophages of the spleen. So the next condition is cold hemolysis, that is known as paroxysmal cold hemoglobinuria. Okay, it's again a cold antibody, cold AIHA condition only. This is a 3 marks question for you. Paroxysmal cold hemoglobin, paroxysmal sudden cold is low temperature, hemoglobinuria, sudden presence of hemoglobin in urine. Okay, it's acute intermittent massive hemolysis after exposure of the cold. Okay, hemolysis is a complement dependent. Autoantibodies are IgG type and they are directed against the P blood group antigen. P blood group antigen is the Donath-Landsteiner antigen. These attacks of PECH are precipitated when the patient is exposed to the cold. Clinical features, they are due to the causes of hemolysis. You have chronic anemia, which is worsened by the exposure of cold. You have Raynaud's phenomena. You have cyanosis affecting the cold exposed regions such as tips of nose, ears, finger and toes. Hemoglobinuria and hemoglobinuria also occur. Okay, when it is exposed to the clothes. Hemoglobinuria, presence of hemoglobin in blood. Hemoglobinuria, presence of hemoglobin in urine. What the treatment consists? Patients, that keep the patient warm and treat the underlying cause. What are the lab findings you see here? Okay, we see chronic anemia, we see low reticulocyte count because the young red cells are being destroyed. Okay, it means the reticulocytes are produced by the bone marrow, it's again the young RBCs again destroyed, so the overall reticulocyte count will be low. Spirocytes, we don't see less marked spirocytes. Again Coombs test, yes, it is a positive direct Coombs test. Okay, why? Because it's again autoimmune hemolytic anemia. The cold antibody titer is very high at 4 degrees Celsius, okay, and very low at 37 degrees Celsius. So next, coming to another classification is drug-induced autoimmune hemolytic anemias. Okay, drug-induced immunohemolytic anemias. So we have 3 drugs here, mainly alpha-methyl dopa, penicillin-induced, and quinidine complex drugs. Okay, alpha-methyl dopa, patients on alpha-methyl dopa, they develop immunohemolytic anemias. Okay, they are resembled with the warm antibody immunohemolytic anemias. Patients with having a long-term penicillins, okay, they too develop immunohemolytic anemias. Drugs such as quinidine form complex with plasma proteins and they lead to hemolysis. So some conditions of hemolytic anemia which are associated with intravascular hemolysis, intravascular within the blood vessel. You have mechanical damage known as microangiopathic hemolytic anemia. blood is flowing in the intravascular and you have some obstruction for the blood cells. Okay, we call it as microangiopathic hemolytic anemia. Chemical damage like burns, infections like you have malaria or babesiosis, transfusion reactions like EBO incompatibility. EBO incompatibility where you have blood group A, B, AB and O, like A have A antigen, B have B antigen, AB has A and B, O and O, no antigens. So whenever incompatibility happens in giving blood groups, wrong blood group to the patient, we see EBO incompatibility. What we see before in hemolytic disease of newborn, it is a RH incompatibility in pregnancy. Here it is a EBO incompatibility. So coming further, microangiopathic hemolytic anemia. This happens when there is narrowing or obstruction of the vasculature. You have the blood vessel, it's flowing through all the body and there is some narrowing or obstruction of the vasculature, abnormalities in the microvasculature. This causes mechanical trauma to the RBCs and this leads to red cell fragmentation known as cystocytes. Cystocytes, I have shown you picture, it's nothing but red cell, fragmented red blood cells. In which conditions you see? You see hemolytic uremic syndrome, thrombocytopenic purpura, malignant hypertension, DIC, disseminated intravascular coagulation where you have fibrin thrombi throughout your body, disseminated cancer, traumatic cardiac hemolytic anemias, also thermal injury like burns. So this is one condition, classical condition of microangiopathic hemolytic anemia. Blood smear findings, you can see the central cells. Okay, rest all cells are normal RBCs, round. Okay, they have central pallor 1/3 RBCs, but in between you are seeing lot of ruptured RBCs. They are not complete RBCs, they are ruptured. These are known as cystocytes. Okay, this is one picture, you can see lot of RBCs. Okay, background is little, but you have in that pink dots platelets. But center one there is a marked RBC which looks like a ruptured one. Okay, somebody has ruptured the RBC. Okay, it's a ruptured RBCs or cystocytes. So what are the other conditions where we see hemolytic anemias in the classification? You have some toxic effects due to certain causes, okay, like malaria. In malaria we see hemolysis, the direct parasitization of the red cells. We call this condition as black water fever. Barytonosis by direct infection of red cells by the microorganisms. Clostridium infection, septicemia by Clostridium vinci by damaging red blood cells in other microorganisms like pneumococci, staphylococci, Escherichia coli also we see such conditions. Red poisoning, yeah, one condition. Copper can also have direct hemolytic over the red blood cells, in which condition we have Wilson's disease. Okay, and patients some patients on hemodialysis. Okay, and also the last condition is snake bite. There is another one condition for cause for extracorpuscular extrinsic abnormalities, hemolytic anemia, known as hypersplenism. 3 marks question for you. What is hypersplenism? We know normally in our body spleen, reticuloendothelial system is present in spleen. The spleen acts as a filter, traps the old damaged RBCs, okay, and destroys it with the macrophages, phagocytosis it, okay, and that is the main function of the spleen, reticuloendothelial system. Okay, normal spleen never poses any risk to the RBCs, but in any case of splenomegaly, the overall functions gets exaggerated. Okay, this leads to unnecessary red blood cells getting exposed, they are destroyed. Okay, beside hemolytic anemia, the spleen destroys the RBCs, we get splenomegaly also, you see. And here it can destroy the all other series also, it can lead to Pancytopenia also. Treatment, what is the treatment for hypersplenism? Spleen is working more, splenectomy, remove the spleen. So this relieves the anemia. So coming to another one condition known as PNH, proximal nodular haemoglobinuria. Before we discuss that condition, proximal cold hemoglobinuria. Same way, this is another condition known as proximal nodular hemoglobinuria. Proximal means sudden. Nodular means in night. Hemoglobinuria, presence of hemoglobin in the urine. So the patient has sudden proximal nodule. In the night, there is sudden hemoglobin appears in the urine. So whenever in the morning he gets and goes to the toilet, he says red color or brown color urine. Okay, that is due to presence of hemoglobin. And this condition is known as proximal nodular hemoglobinuria. It's a rare acquired disorder, okay, of red cell membrane in which there is chronic intravascular hemolysis due to undue causes. Okay, it's due to hypersensitivity of the red blood cells to the complement system, due to defective synthesis in the red cell protein. Okay, normally red blood cells are not sensitive to the complement. Complement activation never destroys the RBCs so easily, but here there is hypersensitivity of the red blood cells to the complement. Why? Because there is defect in the red cell membrane protein. Okay, that defect affects all the cell in the myeloid progenitor, that's RBC, WBCs and platelets also. This is due to mutation of the one gene known as PIGA gene, phosphatidylinositol glycan A gene. Okay, this mutation of this PIGA gene, it leads to the red cell membrane protein defect, and that RBC cells, they become hypersensitive to the complement. So in any condition complements gets activated, these cells get undergo severe hemolysis. Suddenly in the night there will be hemolysis. So there is a somatic mutation in the PIGA gene. This PIGA gene affects the stem cells, pluripotent stem cells in the bone marrow first. Okay, normally we have GPI linked proteins, okay, like which inactivate the complements, that is the CD55 known as decay accelerating factor, CD59 known as membrane inhibitor of reactive lysis. Okay, and also we have CD8 binding protein. These proteins we have on the cell surface which prevents the RBCs from the lysis, okay, hemolysis. But whenever there is a somatic mutation, there is a mutation in the PIGA gene, so we see absence of the CD55, CD59, okay, and these cells, since there is absence of these CD markers, these cells become sensitive to the complement. So such cells are easily get destroyed by the complement. Okay. So what are the lab findings we see in PNH? Okay. We see hemolytic anemia as usual. We see Pancytopenia because it affects the stem cells, so all the three cell series are affected, WBC, RBC and platelets. We have intermittent clinical haemoglobinuria, that is acute hemolytic attack, happens in the night. Okay, and the patient sees the brown urine in the morning whenever he passes the urine. Okay. Haemosidinuria, presence of hemoglobin in the urine is very common. This one condition is also associated with another condition known as venous thrombosis. Okay. PNH is an acquired abnormality which is of intravascular hemolysis, which leads to intravascular hemolysis. So till now we were discussing all the conditions which are extravascular hemolysis. This is one exception in the acquired extravascular abnormality classification, where it is acquired condition but there is intravascular hemolysis. Okay. You see paroxysmal and natural condition, that is by the namesake sudden and night. It happens only in 25% cases. Such cases are associated with iron deficiency also. Venous thrombosis, it's very fatal condition. It can be seen in hepatic portal or cerebral lesions. Such patients have a lot of high mortality. Okay. Few cases, long-term PNH cases, they can go for aplastic anemia or acute leukemia. Acute leukemia is a malignancy of WBCs, what we call as a blood cancer or WBC cancer. They will discuss in WBC chapter. Acute leukemia. Aplastic anemia is a condition where all the cell series they become deficient, where we have in the bone marrow. No? Aplastic means all the three cell series, whatever WBC, RBC means, the cell series become absent or severely reduced. So there is no production of WBC, RBC or cells precursors. That condition we know as aplastic anemia. One class I will take on aplastic anemia at the last. Okay. So PNH, there is high risk of venous thrombosis, and some cases can land into, that is the complications, long-term complications like aplastic anemia and acute leukemia. Okay. This completes today's class. Okay. So next class I will be taking on the hereditary or intracranial conditions like hereditary spherocytosis, G6PD deficiency, thalassemias. Okay. Thank you. Come on.